Good afternoon, everyone. Thank you for joining us. This is Tracy Morton, and I'm joined here with TASC staff, including Nicole Clement, Kate Senyum, Terry Hill, Cami Norland, and then a staff member from the Rhpii project, Leslie Quinn, is also joining us in our office today. And we're really pleased to have you on our second quarter's TASC 90 call today. And today our topic of the day is output. We've all reviewed, hopefully, at this time, the Flex Grant Addendum that was released, really focusing a lot on measuring what we're doing within the Flex program, but also being able to articulate the outcomes of what those trainings or initiatives or consultations might be, and not just counting the trainings and the people that are attending them, but really what the bottom line is that we're driving with the funding that we're available to access through the federal resources provided to us by Rhpii. Today's agenda includes a brief update here from TASC, followed by an update from the Flex monitoring team, and John Gale from the University of Southern Maine is joining us. Then an update from Rhpii regarding activities there and the Mbquip project. And then after that, we'll move into our topic of today on outputs versus outcomes. And we're really pleased to have joining us today the program manager with Rhpii, the Rural Hospital Performance Improvement Project, Bethany Adams, who really is an expert on this. Rhpii has completely refined this process, and they're really, we're looking to model the Flex activities now after what Rhpii has been doing. So we're pleased to have Bethany joining us today. And with that, I guess then I just have a brief update from TASC. A note, again, that the Flex conference is July 10th and 11th in Bethesda, Maryland. We'll be sending out more information to come. Registration will probably be in April. We do have a planning committee that's convened to assist with laying out some of the content, and TASC will be sending out electronically, either at the end of this week or start of next week, to the Flex coordinators, a request for information, probably coming through SurveyMonkey to you, just for content ideas at the conference. So please provide us your feedback. We'd like to make the conferences as helpful to you as possible. A couple other events we have coming up at TASC. There is a quality improvement virtual knowledge group call on March 5th. If you're interested in participating in that, please contact us and we'll get you added to the list. Additionally, there is a virtual knowledge group call on financial and operational improvement on February 22nd. We have a Flex program workshop coming up here in April 24th and 25th. That workshop isn't for people that are just new to the program, but also for those that have been in the program for a while and are looking for an update and refresher. So if you're interested in content that's happening at the workshop or are potentially interested in attending, please contact Nicole Clement.
Also, let me just jump in.
Yeah.
Cindy Large comes every year, so I want to applaud Cindy. She becomes a resource for that discussion, and we have a really good time. Hopefully most of you have made it through that program. So we do want to encourage you to come. It just enriches the conversation, the dialogue, to have folks a little experience there as well.
Yeah, definitely. A couple other things that will be coming out from TASC shortly to you. We're working on the 2012 update right now, the Flex Coordinator Manual. So you'll receive not only a paper version of that, but we'll be posting it electronically as well. And we have a few other initiatives going on. We're going to be working on developing an electronic either module or toolkit about CH Finance 101, kind of the nuts and bolts about CH Finance reimbursement methodology and the important things to know about critical access hospital finance. And then we'll be convening a small group meeting to talk about financial improvement, operations, and sustainability within critical access hospitals. And that small group meeting will be at the start of June. From that, we'll develop a report then to send out to the programs as well.
In essence, what we've been hearing, and I know many of you have been hearing different kind of financial strategies for hospitals, and this is really an attempt to bring some CFOs together, the kind of leading consultants in the country. We'll have Flex program representation, et cetera, just to try to get our hands around what are the financial measures, deepening some of the stuff we're going to see in next year's guidelines, and also hopefully give you guys some additional evidence that, what's been working, what hasn't, et cetera. And so I think it's the first time, at least that I'm aware of, that anybody's really tried to kind of capture that. What is the financial and business wisdom that leads to critical access hospital success? And so we're going to try to define that formula at least a little bit, and I think that'll help build that knowledge base on the financial improvement, because as you all know, things aren't going to get any better from a reimbursement standpoint, at least on a short term. So really, if there are cutbacks, if there are in any way, a lowering of the critical access hospital percentages in terms of reimbursement, they're going to have to make up for it some way. And we think there's a good deal of improvement in terms of efficiencies. It's coding, it's billing, it's revenue cycle management, it's charge master, the very things that you're going to see on this, the next program guidelines and RFP that's going to be coming out. So we're working on that very closely with North Carolina and the Flex monitoring team, with Mike and Rhpii, et cetera. So I'm really excited about that, and I think it may be overdue. We will get something back to you that is understandable, that basically tries to capture as much as we can get from these folks. And as Tracy said, we'll try to, not only a booklet, but another booklet that would talk about basics of critical access hospital finance 101. What are the most important things for a Flex program person to know? So I think you can expect something from us this summer, kind of incorporating both of those pieces.
And then just one other update I had was in terms of the Flex grant guidance about to be released in hopefully mid-March by Rhpii. Please know that TASC is here as a resource to serve you in developing your grant. When you're thinking through objectives and activities, or want to talk through how to measure things or articulate the outcomes, TASC is here to assist you with all those things. We certainly cannot write the grant for you, but we're more than willing to help you review things or bounce some ideas around, or point you to other programs that might have a similar thing going on that you're interested in doing, and connect you with one another. So please do reach out for us for that sort of technical assistance as well.
And then one last thing that I want to personally promote the book that's currently on the TASC book club, Why Hospitals Should Fly, by John Nance. It's one of the most extraordinary books I've ever read. It is basically captured the essence of what we're going to have to do in our hospitals in order to ensure patient safety. And John Nance won an award from the American College of Healthcare Executives with his book for the book of the year. I really strongly recommend it, and please don't hesitate if you haven't read it already or you haven't ordered it to order it from our book club. It's extraordinary and will help a great deal as we look at Mbquip and a lot of the quality initiatives over the next year.
Great. I think with that, then we'll turn it over to John Gale with an update from the Flex monitoring team. And again, John, it's *# to unmute your line.
Thank you. I was just struggling to figure out how to do that. I'll be brief as well. We're well into our current year projects. Some of the things that you can expect to see from us this year will be the ongoing financial performance reports that each of the hospitals get and the states get, and quality from Minnesota. But this year we're also, every other year we do a different set of measures that you'll get reports on. They include community impact measures and HIT. So they'll be coming out probably later this spring. They feed into the PIMS process. We're also looking at, in terms of our new projects, focusing on issues related to the effect of health information on technology on critical access hospital efficiency, development of outpatient indicators for CAHs, financial indicators. We're doing work here at Maine on really digging into the 990s that are being filed. This is really the first year that we should be able to get access to the 990s and the community benefit activities of not-for-profit CAHs. There's a project we're doing on looking at transfer protocols from nursing facilities to CAHs, and we'll also be calling on some of you to, as we dig into our project, to really look at and help assess the impact of state flex program EMS initiatives. So it's a sort of a broad overview of where we are, and very briefly I'll throw something out that we've been working with NOSOR on. Both Charles Owens and I are on a committee with the Center for Disease Control in Atlanta. They've been retained to develop tools and to advise the IRS on the needs assessment guidance. They put together a toolkit that will, a mapping toolkit with the University of Missouri that will allow hospitals to map their service areas and overlay some secondary data on provider supply and poverty and other issues. And they'd like to recruit about 14 critical access hospitals, small rural hospitals, geographically dispersed to work on this. So there was a notice sent out by Charles through the TASC regional coordinators. So if any of the flex coordinators have hospitals that might be interested, you might want to check with the NOSOR regional reps or call Charles or I, and we can give you some of that information. I think that's really all I have, unless there are any questions.
Does anyone have any questions for John on work that the Flex Monitoring team is doing? It's *# to unmute your phone. Okay. I think with that then, we'll turn it over to the folks at Rhpii. I think we have Aaron Fishbach, Megan Meacham, and Mike McNeely on the phone today.
Yes, this is Aaron. Can you hear me?
Hi, Aaron.
All right. I got the *# thing under control. A couple of updates. First of all, I wanted to make you aware, if you hadn't heard yet, that CMS revised downward the rural health clinic and FQHC payment caps that are applicable to independent RHCs and RHCs at provider-based, or that are provider-based at hospitals with fewer than 50 beds, and then all FQHCs. What they found, or what they decided, is that there's an Affordable Care Act provision that applies the productivity-adjusted Medicare Economic Index to a host of providers. It doesn't specifically list RHCs and FQHCs, but CMS has determined that they ought to apply this adjusted version to those updates as well. So rather than a 1.8% update, they're down to a 0.6 update. So it's about $1 per encounter per RHC for those affected RHCs, and more so for FQHCs. The National Association of Rural Health Clinics is challenging that, as I imagine National Association of CHCs will as well. Just wanted to make you aware of it if you heard anything, that their payments have been lowered a little bit, so they received an updated advisory on that. The other two things we wanted to talk about are things that you've heard about before, but that CMS has updated in the State Operations Manual, specifically Appendix W. They're based on two final regulations that have been published in the last 18 months or so pertaining to hospitals. The first is the credentialing and privileging of telemedicine physicians and other practitioners. This was a rule that was published in May and effective in July of last year, and streamlines the credentialing and privileging process for Medicare participating hospitals and CAS, both that are distant site and originating sites. The streamlined process is eligible for the originating sites, or the participating distant sites could be Medicare or non-Medicare participating sites. So the original site hospital, which is the rural site, can now rely on the privileging, I can't read today, I apologize. We now rely upon the privileging and credentialing process of the distant hospital or other entity providing the telemedicine services when making telemedicine practitioner credentialing and privileging decisions. CMS also added provisions that require the governing body of the originating site hospital, through a written agreement with the distant site, to ensure that the distant site furnishes services in a manner that enables them to comply with all applicable conditions of participation and standards. The standard currently requires a CA to have agreements or arrangements with one or more Medicare participating providers or suppliers to furnish these services. However, CMS added an exception to this requirement in cases where a written agreement exists between the CA and a distant site entity for those practitioners to provide telemedicine services to CA patients. So they somewhat streamlined the process and allowed them to rely on the credentialing process of the tertiary center or the specialist clinic. The other provision is patient visitation rights, and you may have heard about this one as well. In April 2010, the President issued a memorandum on hospital visitation, and CMS developed a Medicare standard regarding inpatient facilities to address the rights of inpatients to choose who may visit them while they are inpatients. In November, CMS issued the final rule that became effective January of 2011. As a result, hospitals and CAHs are required to develop written policies and procedures regarding visitation rights of patients, including any clinically necessary and reasonable restrictions or limitations on those rights, as well as the reasons for them. Hospitals are not permitted to restrict, limit, or deny visitation privileges on the basis of race, color, national origin, religion, sex, sexual orientation, gender identity, or disability. Hospital must inform each patient or a representative, where appropriate, of the patient's visitation rights, and each patient must be informed of the right, subject to his or her consent, to receive visitors, including the folks of their choice, and the right to withdraw or deny such consent at any time. Those are the updates that I had. We'll check to see if anybody had any questions on those. Hearing none, I'll turn it over to Megan.
Thanks, Aaron. This is Megan with Rhpii, and I'd just like to give you all a really quick Mbquip update. As most of you know, TASC has been compiling a list for Mbquip partner distribution, and that, I think we've got quite a bit of partners added to that. So the most recent Mbquip monthly that went out also went out to all your partners. So just to save you all from having to forward it on to everyone, you would want to get it. And if you haven't gotten TASC, the list of your partners, go ahead and do that, just so we can make sure everyone's getting all the relevant communications. So I think the most important thing with Mbquip right now is that we did complete our first full quarter for those CAHs participating in this first year. The quarter ran from October 1st, 2011 through December 31st, 2011, and the deadline for getting data submitted from that quarter into Hospital Compare is 11:59 p.m. Central Time on May 15th, 2012, so coming up in about 3 months. And so right now you should be working with your hospitals to make sure that they're getting their data submitted, addressing any issues that they may have, getting them set up with the CART tool if they're not already, and just making sure that that data is in by May 15th, because if it's not, we won't get it when we then get access to the data from the QNet warehouse in Iowa. And in the Mbquip Monthly, we also outlined the upcoming deadlines, just so you can get those on your calendar and set yourself a reminder of when each deadline is for the quarters. And so far, we've heard from one state that all hospitals have already submitted data for the first quarter, so that's great. And we hope to hear from more of you that have also accomplished the same. Just a couple other things. As many of you probably know, either because you were there or because you've seen Dr. Wakefield speak other places, our administrator, Dr. Wakefield, has praised the Mbquip initiative in numerous settings and presentations, and most recently she mentioned Mbquip and its importance for rural quality improvement and building an evidence base at the NRHA Policy Institute that was held a week ago here in Washington, and that just really shows the importance of the project and the impact that we're hoping it has on quality in rural when senior leadership is bringing it up in their presentations. So just, again, you know, it's a great project, it's important, and we really do thank everyone who's on board, everyone who's helping us make it a success, and we look forward to continue working with everyone in the phases to come. And speaking of the next phases, TASC staff is working on rural relevant HCAPS vendors, and so you can watch for a list in the coming months just to help you start thinking about phase 2 and getting the HCAPS data reported for your participating hospitals. And then for thinking way ahead out to phase 3, we are thinking about methods for data collection for the outpatient emergency department transfer communications as well as the pharmacist CPOE, because those aren't currently reported to anything like Hospital Compare that the hospitals are already reporting to. So we are aware that we have to think about data collection for those measures. And just to wrap it up, we're doing a great job. We've got over 900 hospitals signed up. We're at about 70% of hospitals, and so we're about on par with the percentage of hospitals that report to Hospital Compare. So it's great. We have a long way to go to hit 100%, but we're on the right track. And just going forward, if anyone has any questions, don't hesitate to contact me, contact your project officer, or anyone in Rhpii associated with the Mbquip project. We want to answer your questions. We want to provide you assistance. And if you need any training or if you have ideas for educational sessions, please let us know that as well. Are there any questions?
Megan, this is Carol Bischoff in Montana. I was wondering, can you hear me?
Yeah. Yep.
Okay. I was wondering, once the data submission deadline has come and gone, what's the expected turnaround time that we might see some numbers back on our desktops?
Yep, and we're actually, that's a great question. We're working on that right now, just trying to gauge what the data is going to look like when we get it. We're anticipating that we should get it pretty clean from the QNet warehouse, so we're hoping that it's not too much of a turnaround time. We're also trying to figure out what, if any, additional analysis can or should be done. But our goal really is to get it back to you as quickly as possible. And as soon as we have some timelines set, we'll definitely let you know.
Okay, thank you.
Any other questions? All right, Mike, I will let you take it away.
Thanks, Megan. I appreciate it. And in the spirit of the topic of today's task call, we just wanted to give a quick overview of what is considered the process and outcomes measures as it relates to the federal government. In doing so, we want to look at what are the trends in federal programs. Those, roughly through the President's Rural Initiative, there has been a highlighting of the usage of evidence-based to fund activities with grant dollars. So we're looking at evidence-based activities. They could be activities that are small activities that are proven to large programs like IHI. These are things that we are looking at being incorporated into work plans in effect. So what we need to remind you of in reference to this is that we want to move to, as an agency, we're moving towards more defined programs. As an office, we are moving to more defined programs. And this is coming across both the hospital state division and the outreach side of the house, the community-based division. So just as a reminder, these activities begin with just identification of the problem. Then it moves on to identifying what is considered an intervention that could impact that problem. There's the initial baseline identification, and then initiating the intervention. And then at the end of this, you try to establish what the improvements are, positive or negative.
That way you can report the data and you can indicate was it an effective intervention, was it something you really should have tried, or what would you have done differently. These are the ideas that we really are trying to propagate at this point. So on the flex side of things, we're looking at the current direction of the program is to set a minimum standard of reporting on outcomes. For us, that means the new associated PIMS measures that were released in the addendum in December. So with that in mind, we want to make sure that it's clear that those are just the minimum standards. The concept of measurement as being a key factor of the grant work is inherent here. Historically, things have been process-oriented, and process is the first step, but it's not the end game for us. We really want to know what the outcome is and how that outcome impacts the rural safety net. Keeping that in mind, as programs mature and they play with these interventions and these activities that lead to a measurable outcome, some of them will be deemed appropriate, some will be deemed inappropriate. And with those ideas in mind, we will try to remove the ones that don't fit as they're reported to us. So I mentioned the work plan previously, and a lot of times we have a problem thinking outside of our budget here. And the goal of the program and of the office in general across all of our programs is start thinking about the project period. What can you do? The plan. Can you plan for next year using this year's monies? Yes. Can you work towards something that is short-term? Yes. Can you do some of the projects you've been doing? Yes. The biggest thing here is we're really looking at how you're measuring it and trying to determine the outcome of it. We want you to do what you're doing, but we also want you to be able to say, we did this, this is our outcome, and this is why it was important. So when developing your work plans and thinking think about process and outcomes in general, think about what the issue is, what the intervention is, the methodology, your result, outcome, and impact. You put those in the work plans, and you'll definitely get what we're going towards. What Bethany is going to present on is an important step of where we're going. Her information will provide you with a good baseline because our goal in this type of presentation is to provide you across the board for the novices and for the experts. From this, we'll, with John Gale's help, towards the end of the month, we're going to build off of this presentation and do a presentation on logic model, which you'll receive information, and we'll set that date very soon, but it will be either the last week of February or early March, so that you have something to help with developing the work plans for the release of the NCC, ideally on March 15th. With that, if there are any questions, please let me know. I'm open to them.
Mike?
Yes.
It's Between here in Maine.
Hi.
You talk about a 5-year project period, but is the expectation to start a 5-year project period now or to wait till the next competitive cycle?
Well, the beauty of this is that the next competitive cycle is when the next 5-year project period is. You're in year, this is year 3 of the 5 right now. So if you were to start something next year and it was a long-term project, that could be incorporated into your new competitive guidance.
But you could start it next year.
You could start it next year, conceivably.
Okay. Thank you.
No problem.
Any other questions for Mike? Again, hit star pound if you want to ask them. Okay, terrific. Thanks, Mike. And I really like the kind of the process you're laying out here, which is to start looking at, what are the outcomes, what's going to be expected, how do they differ from outputs, et cetera. And we're really glad to have Bethany Adams on. Some of you may know Bethany, those that work in the 8-state Mississippi Delta area. I know have worked closely with Bethany over the years. She is the program manager from Mountain States in the Rural Hospital Performance Improvement Project. And I get to introduce her today, and I have great admiration for her because she is an absolute zealot for excellence, for documentation, just basically for patient safety and performance in general. So we work closely with Bethany on this Rural Hospital Performance Improvement Project, kind of in partnership with the 8-state flex programs, the offices of rural health, et cetera. And I think what's been established in that program is a great model for what some of the state flex programs may be looking at. And obviously, Mike in Rhpii thought so as well. Christy Martinson is the project officer on that program. So what I can tell you is that as Bethany talks about what has been set up in that 8-state region to document the performance, and it's larger than just consultations. It has to do with education, pretty much a full range of activity that all of the flex programs will be doing in this coming year as kind of this first step, then to be followed by the logic model. We're going to be able to provide you with some background to help you put those proposals together for the next grant proposals. So I'm really pleased to have Bethany with us. We will welcome you if you've got questions to ask them. I can also tell you, I can just speak for Bethany, if you have questions after this presentation and discussion, don't hesitate to call her, because she'd be the person that I'd go to document performance in critical access hospitals. And she's just an extraordinary job with the Rural Hospital Performance Improvement Program as well. Chris Tilden, who you folks know, is leading Mountain States right now and is involved in this as well. So with that, Bethany, are you on?
I am. Thank you so much. And thank you, Nicole. And hello to everyone. My name is Bethany Adams, and I'm the program manager for the Rural Hospital Performance Improvement Project. I have several team members on the call with me today, including Chris Tilden, Rhonda Barkus, Terry Hill, Sally Buck, I believe is on, Kate Steinham, and Leslie Quinn. We want to thank you for allowing us to share the RHPI project with you today. And I'm going to see if I can make this work. Voila. Okay, so today's presentation, we will focus on sharing the RHPI approach to performance improvement and our process for documenting outputs and outcomes. We have a lot to cover. This will be a high-level review, we're going to stop in between sections to take questions. If I was in your shoes, sitting at your desk and listening to me, the first thing I would think to myself is, why am I listening, and what does this have to do with my FLEX program? Well, the answer is because Rhpii is the model for many of the new FLEX requirements. So in theory, you should save some time from thinking how to reinvent the wheel. You should not have to sit and think about how to manage the new FLEX requirements. Please just give us a call. Any of us are on the team, and we are more than happy to discuss how the project may be able to assist you. Still getting this to work. Okay, so goals and purpose of the Rhpii project. What is the Rhpii project? First of all, Rhpii is funded through the Office of Rural Health Policy through a contract to Mountain States Group. Mountain States Group is the contracting agency and administers the program. MSG partners and subcontracts with the National Rural Health Resource Center to manage and host the sustainability trainings. And Christy Martinson, she's our project officer, and we are very fortunate to have Christy. We want to thank her for all her hard work and ongoing support. She is just a pleasure to work with. And of course, Chris Tilden, I better introduce my boss here. He is the project director and the executive director of Mountain States Group. And you probably remember the name Chris Tilden. He was formerly State Office Rural Health Director for Kansas. So what does Rhpii do? We serve the critical access hospitals and PPS hospitals in the Delta region, which is highlighted here in blue in your map. We work very closely with our state partners, which includes the Hospital Association, the QIOs, and of course, state offices of rural health. The goal of the project is to improve and sustain financial, operational, and clinical performance improvement in Delta hospitals. Rhpii uses a holistic, a comprehensive approach to performance improvement. Services are designed to assist hospitals in achieving performance and then sustaining those gains long term. And again, please bear with them working on this. All right. So how do we do this? Rhpii has this comprehensive, ongoing technical assistance process. We provide hands-on, and that's the key, hands-on technical assistance through on-site consultations from field experts. In addition to the on-site technical assistance, we support performance gains through the sustainability training. The trainings target the entire hospital, and that is the frontline staff, the managers, the executive team, and board members. Rhpii funds hospitals that meet selection considerations. I briefly want to just point out two important requirements here. First, the CEO must be actively involved and engaged. Why? Because top leadership must drive the project to implement the best practice, to produce the behavioral change in the culture, and to improve performance. Leadership involvement and good project management from you are two key ingredients to obtaining measurable outcomes. The second important requirement that I want to highlight here is that hospitals are expected to participate in the entire process, in all the steps. They must follow each and every step, including sustainability trainings. RHPI ties these trainings to the projects, and then you will hear this theme throughout. And this is a very important concept. I'm sorry, everyone. I'm having trouble just getting my little arrow to work. There we go. Project development. As you can see, we provide a wide range of services, a wide range of performance and quality improvement projects. Hopefully you'll notice that RHPI supports many similar activities that are actually listed in your Flex addendum. The first step in the project development process is to work with the CEO to prioritize the performance improvement needs for the hospital, and then determine how best to serve that hospital. Besides prioritizing the needs and defining the project, we work with the CEO to select the approved consultant that best fits that hospital. We organize interview calls between the hospital and the consultant. These interview calls provide an opportunity for the executive team to explore performance improvement options. After the CEO selects the consultant, then he or she actually develops the scope of work with the consultant and the RHPI team. Each project is tailored to meet the hospital's performance improvement needs, and the scope of work is the guide for the project, and I cannot emphasize that enough. Each scope of work requires upfront planning, which is absolutely a critical start to obtaining measurable outcomes. The sustainability plan should also include action plans that support the implementation process. RHPI projects use a variety of these methods to initiate the implementation process. It could be coaching calls, hands-on training, education of staff, train-the-trainer model, you name it, we basically have done it. Upfront planning is critical. I know I've said that about now 3 times, and that's intentional. Hospitals that complete the project development process, this planning process with us, are ready to move forward and then are funded at that point. RHPI does not utilize a formal assessment to determine readiness. Hospitals that are ready can complete this process. We coach the hospitals through this process, and we really maintain the focus on effective pre-planning the project. I think I want to stop right here because this was, again, very high-level skim of a huge piece of what we do. And I think I want to take some questions here and see if Chris or Terry would have any comments. So questions at this point? Or Chris or Terry?
Yeah, this is Chris. What I guess I'd like to add is that this process of project development steps, as Bethany said, is a very iterative process. It does involve the hospital CEO and other appropriate staff. It involves Bethany and other members of our staff. It involves the consultant. As a hospital identifies a problem, many times they can identify the problem, but they aren't sure exactly how they want to tackle it. Or once a project is completed, exactly what would constitute success, what types of measurable outputs and outcomes might come out of that process.
as Bethany works with them to identify the consultant, there is an ongoing process of refining all of those elements as we move through each project.
Chris, and kind of to add to that, we've done a lot of consulting with rural hospitals, and we've certainly observed consultations as well. Generally, often what happens is that the consultant comes in with kind of an incomplete picture of what is to be accomplished. He or she may have one notion of what that's going to be, and the hospital often doesn't refine it enough to be very clear about what's to be expected, meaning at the end, the consultant could have been doing a terrific job on what he thought the hospital wanted, while the administrator, on the other hand, may be disappointed because she didn't get what she was looking for. And I think that this is really a key point, that getting that agreement up front on what is to be expected, what the outcomes, when the outputs are, takes some time, takes some energy as well. But I think our conclusion and our experience is it produces far better outcomes and outputs on the back end. And it's all part of this process improvement that we've been working on for years down the Mississippi Delta. And I think it's key to the success of successful consultations. And at first we got some pushback from the consultants themselves, because in some sense they are being asked to do way more than they would do under a typical hospital consultation, to be clear in advance of where they're going, what we can expect from it, etc. But I think we've won most of them over in that regard, because the benefits of satisfied hospitals and clear outcomes on the back end, I think, outweigh the additional time on our part, the additional time on the hospital's part, and the additional time on the part of the consultants. So it's all process, and again, process that that we could certainly share with the Flex programs. Bethany in particular is a real expert on how to set these up.
And everyone should have a copy of the scope of work template. Every project should follow that scope of work, and all those pieces must be there, including on-site dates should be pre-scheduled. So there's no surprises. Everybody knows exactly what they're supposed to do. And when the consultant gets there, we expect the hospital to hit the ground running. There's no getting there and assessing. No. We expect them to work when the consultant is there. So that's actually a good lead-in to the next project, which is outputs and outcomes, because we are not finished with the scope of work. Again, the scope of work should drive the project and define the project outputs and anticipated outcomes. During the planning process, we list the anticipated outcomes in general terms. So, for example, the project might be a financial assessment of some sort. The team might decide that the anticipated outcomes would be grow volume, increase revenue, or they need to increase cash on hand. There just seems to be an endless amount of things you could state, but we start with an action verb, and we tie the anticipated outcome to the project objectives. Keep it simple to begin with. I apologize, everyone. I'm just having a hard time hitting this little arrow. There we go. Okay, then, as the project actually has been initiated, and as the project moves to completion, the hospital administrator works with the consultant to, 1, clarify the anticipated outcomes and define them as measurable outcomes, and 2, identify indicators to measure those outcomes. And a measure should be industry standard, accepted financial ratios, operating indicators, and or quality measures. Just depends upon the nature of the project. So, for our example here, measurable outcomes for our financial assessment by the end of the project could be increased total margin by X% from X%, increased days cash on hand, investments on hand by X amount of days, etc. So you get the concept. You know, we make it simple, but then as the project moves forward, they should have defined what they're going to track, and that will be their measurable outcome. And again, I've got to hit the little arrow. So now let's talk about this as another example. I always like to define what is not an outcome, because I do this all day long explaining what is not an outcome. So suppose that the performance improvement activity is a strategic planning project. The completion of the project is not an outcome. It only means that the project has been completed. The development of the strategic plan is not an outcome. The development of the plan and the strategic plan itself is a project output. The development of the plan is really the required deliverable per the activity that will be in your proposal, in your contract, in your activity, in your flex program, etc. The execution of the plan, and that is the implementation of the strategy plan, and the alignment of the department action plans with the hospital goals are not outcomes. That is the intervention. The intervention is the action taken to cause performance gains. The outcome is the result of the intervention. So, what are measurable outcomes from a strategic planning project? Well, here you go. Here's a full list of actual measurable outcomes from one of our strategic planning projects from this year. So it's comprehensive, and these will actually be tracked and by the hospital. This is part of their strategic plan. And I removed all kinds of identifying information because strategic plans are business plans. They are proprietary information for the hospital, so they're not to be shared. The reported action plan should define the recommendations and next steps. We actually require this information in the reports. It does not matter what type of project, does not matter which consultant. This is basic information that we require from all the projects. Most importantly, my words of advice is outcomes are dependent upon the hospital taking the action and not the consultant nor you. The hospital must have the ownership of the project to make it successful. And we know that performance improvement, quality improvement is always ongoing. RHPI projects are designed to be sustained post-project, and hopefully should be a springboard for the hospital to go to the next level, to move to the next performance and quality improvement initiative. From our experiences through the RHPI project, many of our hospitals are still just down here at the starting point, and many of them are in process of actually implementing best practice concepts. And I really liked the term, a promising model, that's actually in the Flex addendum. So I actually utilized it here to capture the concept of going from starting with baseline information, implementing some consultant recommendations, which are best practices. I really want to emphasize that. And then if they have solidified that, they are ready for, and where the Flex program is going, evidence-based models. So how do we document outcomes? Well, RHPI does it through recommendation, adoption, progress reports. We utilize it to capture outcomes, and we also share success stories through hospital profiles. You should have an example of both in your handouts, and I encourage you to look through that to get a feel of what kind of outcomes we actually capture. In 2010, RHPI project adopted a new reporting process. We call it the Recommendation Adoption Progress Report. It took us a while to get this acronym RAP report. We're actually pretty proud of that. The purpose of the RAP is to gather information on the adoption of the consultant recommendations by interviewing the CEOs about 1 year post-project. The goal is to demonstrate that a hospital's progress over time by showing the extent to which the facility has implemented recommendations. Again, those recommendations are best practices. The concept is the higher the RAP score, the greater number of recommendations were implemented by the hospital. So therefore, the hospital should show evidence of performance gains. And we have evidence to show that it takes at least 2 years to fully implement best practices, recommendations to sustain the project. Therefore, again, I just cannot emphasize this enough. The hospital should utilize those indicators and measures that are developed in the project to monitor their performance gains and the direction of their projects over time. We understand that there are many variables that impact performance, but because they are tracking these indicators or measurables, and they carefully have a plan that they are following, the hospital can justify and explain those variables that could enhance or impede performance, which is, I believe, one of the requirements in the Flex addendum. And that is important. If you get a null or negative outcome, again, that's one of those lessons learned that you want to get out there and share and hopefully learn from it. So today's take-home message, at least for this part, if you want measurable outcomes, you need to plan for it. And it's just good program project management. And I wanted to stop here for just a moment, and before we go to the next section, and just put side-by-side visual of the RHPI process next to the AHRQ toolkit process. I'm so sorry. As you can see, truly the approaches are very similar. Again, I think I want to stop right here because this is once again a high-level overview, and I'm sure you have many questions. And I also want to see if Chris and Terry want to add anything at this particular point. Questions?
Bethany, this is Tracy. I have a question. I know that in RHPI, a lot of the work is individual hospital consultation with one hospital. And in the FLEX program, many of the projects actually happen as a multi-hospital kind of venue. Can you explain how maybe this process could be adapted to work in a multi-hospital environment?
Absolutely. Again, it definitely can be adopted because first, start with the planning process. You still need a scope of work, and you still need a plan in that scope of work. Your strategies, your anticipated outcomes, what you're going to monitor and track, eventually get through the process. So this is just not for one project and just not thinking it from the perspective of, well, it's a contract with a consultant. Many of you probably would manage it through your own FLEX program. Again, then I have to honestly say, either way you look at it, you need to manage your FLEX program, and you need to hold both the consultant and the hospital accountable. They're utilizing federal taxpayer money, and if they're going to be part of this process, there needs to be a commitment to step through each of these steps. This is just basic project management. So it doesn't matter if it's just one hospital or if it's a group of hospitals. Definitely the planning process to put it together a plan and use that scope of work as a guide can be scalable, absolutely. And let me also emphasize that once the hospital decides that this is it, this is what we're going to work on, and we put together a scope of work, and they confirm it, there is no change in it. We expect the hospitals to use it as a guide all the way through. We expect everyone to have a copy of it in hand. There should be no surprises, no deviating from where they want to go, and to keep everyone on track for the timeline. They create their timeline as well. I hold them to it. So I hope that answered your question, and I'm sure that Chris could, or Terry could probably add a better answer in terms of a group, thinking more of in terms of a state partner. Chris, Terry, you guys want to add anything?
Bethany, this is Chris, and I don't really want to add much. I agree with what you're saying about the ability to, to modify this to support group work. Most of the work through RHPI is focused on the individual on-site consultation. There is, as Bethany mentioned, in collaboration with the Rural Health Resource Center, we do an extensive amount of work on promoting sustainability of the programs. I think Bethany's going to talk a little bit more about that before we wrap up here. But that process of which really is one where through a series of webinars and knowledge exchange also promote learning among the participating organizations. And again, I'll leave it there because Bethany, I think you're going to talk a little bit more about that.
Yep.
Right, let me jump in as well. Another question came up of how many hospitals are we working with in the Mississippi Delta, and there's well over 200 that are there. The data is, I mean, I'm really impressed with the data we've generated, but the stories are even more impressive. This has been an incredibly popular program with the hospitals down there. The feedback we get is absolutely outstanding from the hospitals themselves, and that's very carefully tracked. And I don't know, Bethany, if you're going to talk more about that, but I'm really proud as to the feedback we get from those hospitals, and that's great. But the feedback itself, the stories, the appreciation is extremely important, but we have to document it. That's only part of the story. The documentation is almost equally important in this era, and so just wanted to throw that in as well. A lot of hospitals, 8 different states, the most financially challenged, I will bet, area of the country, particularly in the Mississippi, Louisiana, kind of Arkansas, and some of the southern parts of that 8-state region. And we've just seen outstanding results coming out of there in terms of financial improvement, in terms of quality improvement, et cetera, just outstanding leadership as well.
And we had a few other questions come up in the chat box, so I think if we can address those.
Yeah.
Roll up a second. There was one question that came from Sarah Roberts in Kansas that says, it's a question for Paul or Megan if you're still on and available, about reporting outpatient measures in Phase 2 that critical access hospitals need to sign a separate online outpatient quality reporting program pledge that's different maybe from the inpatient hospital quality form by March 31st in order to submit any 2012 data, and she's just wondering if that's valid or not.
Is this a question, I guess, for Terry? Is this really a question for Mike?
We can also address this offline and send out a message to everyone, too.
Yeah, this is Megan. I haven't heard anything about that, but we will look into it and then get back to everyone.
Great. And then John Ike in Wisconsin had a comment and a question, too. He noted that the distinction with the state level is not that the hospitals are not committed to tracking, but that they're doing broad, shallower projects versus the one-on-one intensive interventions with a single hospital. And he had a question then that for some reason is not coming up on our screen. John, if you're on, oh, there we are. He's wondering if we could clarify, Bethany, the difference between a promising model and an evidence-based model in your diagram. Rhpii also had that definition defined in the addendum that they released as well.
Yes, and the evidence-based model is being rigorously tested, scientifically based, confirmed processes that show evidence of success. And again, best practices being concepts of processes that the hospitals, what we consider today that they should be doing to maximize their profitability or improve quality, etc.
Bethany?
And I guess what, yeah.
So my question was actually not, that was no good question. I know the difference between the two. I didn't understand it in your diagram. You said that the first thing you do with the hospitals is get together with them to set objectives. The next thing you do is pick a promising model. And the third thing you do is go with an evidence-based model.
Oh, I understand. You were talking about that. I was trying just to have a little bit of an overview, and where the Flex program is going. I apologize. Let me just see if I can't go back there. Just one moment, please.
There you go.
And what I did say was, for this particular slide, is majority of our hospitals are really at the starting point. Again, just baseline information. They're really struggling. And to be exactly what Carrie said, this is one of the poorest areas in the country, and they are really at baseline starting points. Many of them do not have best practices in place, and we really do help them develop that. So trying to follow along with where the Flex program wants to go is, and I was trying to illustrate that you just can't just jump into a evidence-based model when you don't have some basic fundamentals in place, and that is just some good best practice concepts of what they should already be doing, because they just really not be ready. So ideally, would we like to be doing a large evidence-based model? Oh my goodness, I'd be thrilled to death. Could we, as if I was a Flex program director, would I be thinking about how to get baseline and then helping them actually implement practices, best practices? Absolutely. And then would I be trying to coach them into, say, some sort of a collaborative, sort of following the IHI collaborative? That's what I was sort of thinking of moving forward in the future. So I was just trying to capture where the Flex is going and to show that our hospitals are truly this baseline starting point, and they are implementing best practices. So I hope that answers your question, and I'm sorry for the confusion. Does that answer your question?
Yeah, thanks.
Okay. So we will move on to tracking outputs. Oh, I think, did I skip where I was going? I am so sorry, everyone. Yep, here we are. I apologize. I'm still learning how to work the little arrows. Okay, so we know that in the Flex program, and particularly with the upcoming changes, you're going to have to track many new requirements or many new items to track in your Flex addendum. We want to provide a few words of encouragement, and we know that tracking is quite a challenge, but we're here to say that, one, it's doable, and two, it's extremely important. And so first of all, just why do you need to track the outputs? It's because we need good information to manage our programs. It's just good business decision making. Your Flex program is your business, and you're charged with effectively managing federal dollars. So outputs and trends may be used to monitor program activities, support program modifications, justify funding, direct resources, predict future program participation, estimate program costs, determine how best to market your trainings and target your services. It just seems to be about endless, about why you need to track program data. So where to start? Well, we use the old rule, count one thing, one time, and one category as a place to start. If you do that, that's a pretty good place to start. I've just put something here as an example for you to see of one of the main trends that we look at in RHPI. In RHPI, we track numerous outputs. We have huge amounts of data, and we've developed a reporting process that defines the information flow. We preserve the data. We develop reporting templates. We track them in Excel. When we put it in Excel, then as it's populated, it's actually calculated. And we actually even use some of the Excel as a scoreboard, so to speak, for internal monitoring. Lastly, bottom line is you must have an output before you can determine a trend. And you need that output to have an outcome. So we want to share in your pain in this, and it's an important piece of any program management, and whatever we have at our disposal, we would like to just share with you. And then the next part for trainings, again, I know for the trainings, for the new flex requirements, you're going to have to actually utilize evaluations to evaluate or assess your trainings, and possibly even a second follow-up. Again, we understand, yes, this is quite extensive process. We do it quite often, and we want to offer any kind of templates and questionnaires, etc., that we may have. I want to refer you to one of the handouts called Training Documentation Handout. This is a RHPI internal document that we developed with Christy to help clarify expectations for documenting training outcomes. This is still a work in process, and I hope it's going to be helpful to you. But a few key points here regarding evaluations. And for all of you that are there that are traditional, that have been in this for a long time, please hold on to your seat, because I know you're going to say, what? So, first, this is not proficiency testing. We know if you do trainings, obviously, what happens is you're actually having questions addressing to the impact on the individual. While education of the individual is important to capture capacity building, the outcome that we really want to achieve is how that training actually impacted the hospital's performance. The second thing is we really just need to move away from, get rid of traditional conference evaluation questions, including speaker effectiveness questions. They're just not helpful. You only have one piece of paper, basically one chance to capture how did your training impact that hospital. So we really need to have questions that focus on, again, how did that individual utilize that information? And I guess as part of this, and I put this on my slide, is as far as I'm concerned, this is truly a work in progress for all of us on this call. And we really do need to standardize some questions across the country to really define and how to capture that information. I think all of us need help on that. And I just wanted to show a few questions as an example from RHPI. Again, we are trying to evaluate the effectiveness of the training by determining the degree to which the participants may utilize the information. Does the participant plan to implement the best practice that he or she learned? What do they plan on doing with that information? Are they actually going to go and try to put it to work in their hospitals? Again, while it'd be very easy to get caught up in evaluating the individual and their education level, but that doesn't have anything to do with hospital impact. So again, I know this sort of blows everybody away because this is more of my own personal opinion, and there are very other people who are real experts on evaluation. But I really want to put this out here because this is an issue for all of us. And I think I wanted to just stop here for just a moment and say questions, comments, because I'm sure I'm going to get some on this one. And Chris, Terry, to see if you had any comments as well.
Well, I think we were impressed with your suggestions, and we were just looking at our own task evaluation saying, gee, we don't have that way. So we've resolved to throw some more outcome questions into our evaluation of our task ND calls and others as such. I don't think what you're saying is that we shouldn't be evaluating the performance of the speaker or the trainer, because that's important just in terms of whether we're going to use that person again, et cetera. But I do hear you saying, in essence, the so what question comes out. We could have a brilliant speaker, everybody's entertained, but if it didn't do anything to improve the performance of the hospitals, then perhaps it kind of be beside the point, other than it's great to be entertained, so to speak. So I like the thought of incorporating.
Absolutely. And, and even around that, I can say that, yes, I've been at many conferences, and I try to fill out my evaluation form, and some of the other traditional feel-good questions that are on there are taking up good space on the paper. Do I like the venue or the food good, or again, 10 questions or several questions on the effectiveness of the speaker. We only need one question really regarding the speaker. Again, those type of questions have always been there to, trust me, if your hospitals don't like a particular place, they're going to tell you in the open comment section. So we really do need questions that help capture the training on the hospital overall. So I hope that one document that I also sent out sort of summarizes this process. And again, any of our questions or templates, we are welcome to share. And we intentionally keep our questions to just a few. One, we want feedback from them, and people get tired of answering a bunch of questions. So we really want to target to a few key questions. So any other last comments regarding this?
Well, it's basically a continuation of the less is more. And this is classic with hospitals in general. We gather so much information, the really important stuff gets diluted with all the other stuff we have out there. So I totally agree with you, Bethany, that less is more in this regard. Let's ask the most, the 5 or however many most important questions, and let's leave some of the questions of lesser importance off of there.
Absolutely, absolutely. And then the next part is just to emphasize this very quickly. Whatever we have, we hope that you take advantage of. One of the things that we are very proud of is the playbacks. They're free, and we encourage you to go to the website and have your hospital to utilize it. You know, we have, Eric Shellhead did a 6-hour presentation on financial management that's just top-notch that all hospitals should listen to. Pat Shaw, he is an excellent trainer. Again, both of those, it's 6-hour trainings, and please take advantage of that. And then, of course, anything that we have to offer, we are welcome to share. And then the next piece, I know that you're sort of getting tired of listening to me talk, so I want to sort of open this up. Oops, I want to go back right here for just a second. You should have in your handouts a RAP report, and it shows about, I think, 8 or 9 hospital summaries that has just a couple statements from the hospitals, some outcomes, and just sort of an overall impact. It gives you a little snapshot of what we do. And then also just a sample of the profile of one of our hospitals, Muhlenberg Community Hospital from Kentucky. And right now I want to turn this over to Chris and Sarah and Rhonda, and let them talk a little bit more about RAP and how they use RAP to capture some of the outcomes from some other projects. So one of the questions earlier was, well, can this be applied, and is it scalable to multi-hospitals? Well, you're actually going to hear that, yes, they applied the RAP process to a Kansas project to try to capture and document some outcomes. So, Chris, are you there?
Yeah, I'll just, and we want to keep this short, but you know, I was talking with Sarah Roberts in Kansas shortly after I had taken over at Mountain States Group, and after Rhonda had joined the Rhpii team as well, and Rhonda and Bethany had started working on this recommendation to the adoptions project reporting process, and I was just commenting to Sarah, I think we were at NRHA a year ago, commenting on how impressed I was with the information we were capturing about project outcomes, and using this process. Rhonda has been overseeing the RAP reporting process, conducting the interviews with the CEOs. As we talked about this, you know, I commented on the fact that, you know, in Kansas there really had not been a comprehensive assessment of the work that they had done within their quality improvement project, much of which centered around work being done by Darlene Bainbridge with a vast number of the majority probably of critical access hospitals in the state of Kansas. So Rhonda and Sarah sat down and formulated a survey, and also decided to select a random group of hospitals to go through an interview not too dissimilar from what we do with the Rhpii project, to gather information from them on outcomes from the program, even though it wasn't structured in the way of Rhpii with the hospital-specific outcomes and output measures being defined up front. I think the results from that survey were and assessment process, I think, of a fair amount of value to Sarah in terms of looking at how they continue to structure their ongoing efforts. Rhonda and Sarah, I know, are on the call, so if any of them had anything to add, I'll turn it over to them.
Sarah, do you want to just speak about some of the project and how things went?
Sure. This is Sarah Roberts. And so two of the things that we wanted to do, and I think we achieved from just this project, was one, we've done assessments or an evaluation, and we looked at what we heard our hospitals, their satisfaction in the services we provided, and then we did other studies to look at a survey at leadership levels and financial information. That was when we looked at the summative evaluation, though. Our program was pretty inconclusive of have we been successful in helping improve the performance of our hospitals. So by taking the Rhpii model approach for this, we were really able to identify for some of our hospitals what they saw as some measurable successes and even some unquantifiable successes, which I thought was really a great thing to have. And from it, we also learned, I think, ways to improve how we go forward in our planning for certainly quality, the side of quality, but as we build in financial performance improvement activities, how to structure it that in a way that models the Rhpii